Hello again. It's Dr. Eric Goulder from the Heart Attack and Stroke Prevention Center of Central Ohio. And today I want to talk with you just a little bit about how we use the Carotid Intima Media Thickness Scan, or the CIMT. To understand what this means, if you look at this slide, you'll see that there is a picture of a coronary artery. You've got a central lumen. There's a thin layer called the intima. And then below that is the muscle layer, which is known as the media. And we measure those two layers together to come up with how thick your arterial lining is, because when you develop cholesterol buildup in the lining of the artery, it's all building up in the intima. Nothing changes with the muscle layer, so that stays the same, and we can measure that and know how much cholesterol is building up in the intima. Then outside of that is the outer wall. So we use this scan to look for silent arterial disease. It's an easy way to evaluate your arterial system without using needles or contrast or anything like that. And what you're looking at now is a picture of the carotid artery. On the right side of your screen is the beginning of the common carotid artery as it comes off the aorta. It then goes on up your neck where that line is. It's widening out into the carotid bulb. And then there's a branch point on the left side of your screen into the internal and external carotid arteries. And if you look at that screen, you can see that there's a box drawn there, and we're going to measure in that box in the common carotid artery at 100 points how thick your arterial lining is. When I do this scan on you, as you probably know because you've had it done before, we've got 6 of these boxes, 3 on each side of your neck. And so we've got 600 data points. It's a very accurate number as to how thick your lining is. And we know how thick it should be for everybody from ages 5 to 80. If it's within 5 years of your chronological age, we're going to say it's normal. If it's 6 to 10 years older than your chronologic age, we're going to say you've got moderate increased risk of having a cardiovascular event, heart attack, or stroke. And if it's over 10 years older than your chronologic age, we're going to say that you're at severe increased risk. And then if you follow that lining layer out past that vertical line into the carotid bulb, you can see that there's some plaque in that bulb. And the definition of plaque is, again, 1.3 millimeters of thickness or more. And when we look at these reports that come back on this test, you can see there's all sorts of combinations that occurred. Nobody really follows the book, okay? And so you can have a very young arterial age, almost 20 years younger than your chronologic age with no plaque. You can have a very old arterial age, 17 years older than or more older than your chronologic age, again with no plaque. Or you can have plaque and a normal arterial age. Or you can have plaque and an increased arterial age. And each of these gives you a variation on your personal risk for having that cardiovascular event. This is a very different test than they do at the hospital where they do carotid scans, because they are doing what's called a duplex or a Doppler flow carotid scan. And this scan is looking at the velocity of the red blood cells going through the artery as opposed to looking at the wall. So they don't have any protocols for measuring that thickness of the arterial wall with this scan. And when we do this scan, it gets read in tenths and hundreds of a millimeter. So it's a very small differences in the lining thickness that can have a significant difference in your risk. So this is an example of what some significant plaque would look like in a carotid artery with that plaque on the near wall and the far wall. And if you look on the right side of that slide, you'll see a transverse view where you're looking right down the barrel of the artery. You can see all that plaque all the way around. The bright white line on the outside is the outer wall of the artery. But that gray hazy stuff in the middle is plaque. And so if we look at this scan, you'll see that there's thickening of the arterial lining. And if you can imagine that thickening being pretty consistent and concentric. So if we look at this artery and say, okay, it gets this thick now, then you're going to say, and if you were doing a cardiac catheterization, you would look at that artery and say, that looks pretty normal. It's nice and smooth. And you couldn't tell that it shouldn't be that thick. And so this is a typical example of a coronary artery. This artery is probably normal, but this person could have diffuse concentric disease, and you wouldn't know it by looking at this scan. So looking at the wall of the artery is often much more helpful than looking at just the lumen of the artery where the blood flow is going through. And so what we want to do with this scan is we want to take your soft inflamed plaque like you see on the left side of the screen there, and turn it into that rock pile, that totally calcified plaque on the right side. These are not the same patient, but you can see when there's a really calcified plaque, there's a dropout of the echo below that plaque, and that's that shadowing below the plaque, and that says this plaque is very calcified and much more stable. And we know it's much more stable because they did a study looking at people with carotid plaques. And what they found was if you have soft inflamed plaque, it's much more likely to rupture over the next 2.5 years than if you don't have soft inflamed plaque, which is much less likely to rupture over the next 2.5 years. So obviously that soft inflamed plaque puts you at significant risk. And again, we want to turn it from that into that rock pile. So the question is, how do we do that? How do the arteries heal? Well, the soft inflamed plaques, like we were just talking about, those are the ones that are most likely to rupture and cause a cardiac event, a heart attack or a stroke. By controlling all the sources of inflammation that we know of that can drive this arterial disease process, we get the cholesterol out of the plaque, we get the inflammation out of the plaque, and we allow that plaque to heal. Your body heals it when we get the inflammation out. It's the chronic inflammation that causes the problem. So with the inflammation out, that plaque's going to shrink down, it's going to calcify, and it's going to stabilize. So in what ways is the CIMT useful in defining arterial disease? Well, we can look at that arterial lining wall and see, yeah, your arterial age is increased and you've got increased risk. We can look at that arterial wall and say, no, your arterial lining is way thicker than normal. You've got a very healthy lining. We can find evidence of plaque, and then we can actually look at that plaque and say, what's the quality of that plaque? Is it soft and inflamed? Is it a mixed plaque, which means heterogeneous? It's got some calcification going on, starting to heal. Or is it all echolucent? Is it a rock pile and it's stable and not going to cause you any trouble? And so how can we use the CIMT to follow arterial disease over time? Well, if the disease process is improving, that arterial lining is going to start to get thinner and thinner and thinner and go back down towards normal. As the plaque stabilizes, we get to see more and more calcification show up in it, which means we're getting the inflammation out and the plaque is becoming more stable. And once that plaque is all calcified, again, it's a rock pile. It's very unlikely to rupture and cause you a problem. So the question is, who should get a CIMT scan if you've not had one done already? Certainly everyone by the age of 40, I think, should have a CIMT scan. Find out if you got that early silent disease that's going to progress and cause you trouble down the road so we can do something about it. If you've got a family history of significant arterial disease, a parent, brother, or sister who's had a heart attack, a stroke, stents, bypass surgery, you should get a CIMT scan done. Anyone who's already had a cardiovascular event should certainly get a CIMT scan done. We want, if you've had that heart attack or stroke, stent, or bypass, we want to stabilize all your other plaques so you don't have another event. And finally, anybody who's got any one or more major risk factors for cardiovascular disease should get a scan done. If you've got high blood pressure, high cholesterol, smoking, diabetes, get a CIMT scan done so that we know what your risk is and we can do something about it.